Thank you, Dr. Strauss. As you can see, it's been a pleasure working with David for a long time. He's very knowledgeable. He's taught me so much in the area of mycology as well as in mycotoxins, and it's just fun to work around him. My area that I'm speaking on today is on mycotoxins, its structure, function, and testing procedures. The goals of my presentation are to define the mycotoxins, especially aflatoxins, ochratoxins, trichothecines, and then some of the others like ergotamines. I'm going to show you the structures of the mycotoxins. I'm going to discuss a little bit about malignancy and what we have found in mycotoxins in their association. And then another question that a lot of people have asked, which interests me as I get older, does aging correlate with mycotoxins and especially antioxidants, which then leads us into discussions of antioxidants and glutathione discussion. I'm going to explain the testing of the mycotoxins and why we decided to go in the direction that we did, the validations of the testing in a laboratory setting, which is a huge discussion in laboratories as well as in our regulatory issues and in litigation. And we're going to explain findings to date in the specimens that have been submitted for clinical testing in body fluids and tumors. Mycotoxins are, as you heard through Dr. Strauss, they're toxins which are produced by the fungal elements, and they're called mycotoxins because they come from the area of mycology or molds, and they're toxins. The mold or fungi produce these mycotoxins to destroy other microbial competitors, i.e. bacteria and other fungi. And they are ubiquitous in man's environment. When they come in contact with our cells, in man or animal, they can cause cell damage and thus the cell ages. When they're present, there's a pronounced free radical and adduct formation in the human tissue. So, the presence of a laboratory measurement for the presence of mycotoxins in patients would be extremely helpful to medical caregivers. And that's the reason why I started looking at these years ago. My history is that I worked in the Navy for too many years, but I retired and I worked with, as a pathologist, I looked at a number of cancer-causing agents. And I went to a number of courses in the military that discussed biowarfare. And I heard of these things called mycotoxins and knew nothing about them. And still, when I left the Navy, I knew about the same amount, nothing. And I heard of them through conferences held by Dr. Ray at the Environmental Health Center, and became very interested in those more so after I met him. So we know that the body's designed to heal and repair itself, and the body can repair itself properly if it cannot repair itself if it's overwhelmed with toxins, which are insulting the human body. So we know that it's a poisonous substance produced during the metabolism and growth of certain microorganisms and some higher plant and animal species. So what if we have mycotoxins? For years, we all thought that there were such things, but what do we do? Is there an ability to measure these? So the ability to measure the presence of toxins would help not only to tell the physicians that they're present, but is there some way to help in anti-aging and repair, to better understand the mechanisms of effective mycotoxin neutralization, which is extremely important through some universities, and how do we remove these mycotoxins from patients? That's why we're having the roundtables at the end of each of 3 talks. And then we're going to have discussions at lunchtime on how people think that they are removing these and how they would suggest removing these in the future. In a normal situation, there are intracellular mechanisms to eliminate toxins. And thank God for that, or else we would not be here. Problems occur, however, when the normal mechanisms of removal are compromised. In the human health burden, we can see there's related to chronic exposure, even though the best known mycotoxin exposures are manifestations of acute effects, i.e. ergoticism and Stachybotrys exposure. We have been studying since Realtime has been formed whether or not these do produce cancer. We believe they do. We have been able to find them in some malignancies, which we'll talk about. And we know in the literature, as Dr. Strauss has pointed out, that some of these are definitely carcinogens. The history of kidney toxicity has been well documented on the ochratoxins, and we'll talk about that one. Immune suppression is also extremely important. We see this with the mycotoxins, especially trichothecenes and ochratoxin. These are the structures that I'll point out that are present in your booklet. The major ones that we have been always interested in are the B1, B2, G1, and G2 of aflatoxin. B1 is the isomer is the most potent natural carcinogen known, and it's produced by Aspergillus flavus and Aspergillus parasiticus, but it's also produced by other organisms. And the liver is the primary target. However, we have found them in lung and in brain. And the literature backs that up. Ochratoxin A is another multi-ring structured mycotoxin. It's formed in the literature by Aspergillus ochratius and Niger, Penicillium verrucosum. Interesting, especially in legal cases, they always say these buildings and the schools or the homes where these patients got these mycotoxins from, it really doesn't exist because they've eaten them. And it's true. They're found in grains, coffee, beans, and some wines. And the FDA and the USDA does monitor the amount of ochratoxin in these foods. And they will reject any coffee or any kind of products that are being imported if the ochratoxin is too high in the foods. Ochratoxin A is nephrotoxic. The humans have the longest half-life for its elimination of any of the species studied. I do a lot of legal discussions and involvement with patients in legal cases. And one of the biggest issues that they have that the other side brings up is the half-life of ochratoxin is 32 days. And that's true. It is in serum. I have seen nothing in the literature that says what's the half-life intracellular, inside the cell. So that kind of goes by the wayside because all of these toxins become intracellular, and that's where they cause the havoc in the humans. So if other people argue with you as a clinician or in some kind of discussion in a bar or something, that ochratoxin A has a short half-life, you can argue the intracellular aspects of this organism or of this toxin. It's again, it can cause birth defects. It's a carcinogen, and it's been associated with urinary tract infections and bladder cancers. It specifically inhibits synthesis of phenylalanine transfer RNA complex and inhibits mitochondrial ATP production, and it stimulates lipid peroxidation. The trichothecenes that Dr. Strauss mentioned are very complex and very difficult for me to get a kind of a handle on. As he pointed out, the macrocyclic trichothecenes are quote, simple structures. I don't think these are simple at all, but they are produced by Fusarium, Stachybotrys, Trichoderma. Those are the major organisms. And we looked at T2, we looked at the macrocyclics, especially satrotoxin, and we found that we couldn't isolate in any body fluids, the T2 structure. So we went for the other macrocyclics, and we have, in our test, we have 10 different macrocyclics that we believe are what we catch in our ELISA test. The trichothecenes are potent inhibitors of protein synthesis. Some interfere with initiation, others elongation, and others termination stages of protein synthesis. So it depends on which trichothecene we're talking about. They all inhibit peptidyl transferase by binding to the same ribosome binding site. And you saw what symptoms that Dr. Strauss described as being caused by trichothecenes. So how are human cells protected normally? The human cells have protective mechanisms to deplete free radicals and other reactive chemicals. They have an entire array of free radical scavengers and enzymes, and we're very thankful for that. They have transcription factors in the nucleus, and there's two proteins that we at Realtime are very interested in, and Dr. Guilford will talk about these in great detail, and that's I call it the NERF2, or the nuclear factor erythroid 2 related factor, and KEAP1, or Kelch-like associated protein. The mycotoxins stop or deplete these two proteins. So the mycotoxins stop the body from getting rid of free radicals. The free radicals, as you know, are bad for our health. The exogenous sources of free radical stress, like mycotoxins, create a critical depletion of these scavengers, the enzymes, and NERF1 and KEAP1. In turn, the immune and endocrine systems can be severely affected, which then can create a vicious cycle for accelerating the oxidative stress and aging and inflammation. Such activities can and do contribute to premature aging, disease, and malignancies. So free radical stress, you've all known this from all your reading just in the newspapers, but the major contributor to aging and disease states is free radical stress, as well as to diseases like atherosclerosis, myocardial infarcts, stroke, asthma, Alzheimer's, Parkinson's, and cancer. Oxidative reactions are crucial for life. Oxidative reactions can be damaging. Low levels of antioxidants or inhibition of antioxidants and enzymes cause oxidative stress and may damage or kill the cells. So the humans must keep replenishing the antioxidants, or their cells can be damaged or killed. And so these are, the list is very long. We're very interested in glutathione, but many of you use a lot of different areas. Vitamin C, vitamin E, enzymes as catalase or superoxide dismutase or peroxidases. So what's the dilemma that we came up with in my learning about the mycotoxins? Is there a correlation between mycotoxins and aging which causes these cells to slow down in their metabolism? And is there a correlation between the mycotoxins and malignancies? And is there a causation, which we now try to stay away from causation words because of the legal issues involved there? So we say there's an association. Dr. Strauss taught me that word. Don't say causation. So the mycotoxins, as we pointed out, are low molecular weights. They usually are produced as secondary metabolites. We know there's thousands of these things, but 300 or 400 are recognized as mycotoxins that the literature talks about extensively, but only 10 or 12 of them receive attention by any of us. Most of the literature attributes mycotoxicosis to ingestion, but we, in our group, as well as you know, that they are associated with airborne contamination. The effects of mold and mycotoxins, we believe that, and we know that there is a hormonal effect. It disrupts estrogen function and disrupts thyroid activity. We have found that the chemical structure of mold mycotoxins are very similar to the PCBs and other pollutants found in the 9/11 disaster, and that the literature is cited in your handout. Now, the reason that I put this slide on is because in validations in a laboratory setting, we have to say, well, are we really measuring these toxins, or are we measuring something else that are similar? So we had to look at a number of hormones, especially estrogen, progesterone, testosterone, and some of the steroids, to see if, do we pick those up instead of the toxins? Because if you look at those structures, they're very similar to some of the hormonal structures. So we asked, can mycotoxins be measured in human fluids and tissues? And we answered that we believe in a paper in 2009 titled Mycotoxin Detection in Human Samples from Patients Exposed to Environmental Molds. This paper, we believe, was important because we looked at 54 or 56 patients that I went around all around the building where Dr. Ray allowed us to work when we first got started. And I asked people, have you ever been exposed to molds knowingly? And do you have these symptoms that CDC states? And some of them said yes, some of them said no. So those that said no, I said, would you give us a urine sample, which they thought was very strange, but we got it. And we did an ELISA test that we thought of because that's what they were looking at in foods. Now, we're not geniuses in thinking of this test because it's something that they look at. They look at trichothecenes and they look at aflatoxins and ochratoxins in foods. So we thought, well, why not use the same kind of test but adapt it to urine or blood? And we tried that in blood. It didn't work. We couldn't find them. So we went to urine and tissue, and that's what we found. If we seeded the urine, if we took a negative urine and then put normal trichothecenes or aflatoxin or ochratoxin that we bought from a chemical company, put that in the urines at different dilutions, we could find what our level of detection was in those specimens. Then we went back and looked in the humans that were affected, especially from Dr. Ray's group, where we first got our specimens. And we found them. We found trichothecenes. That was our first test. And we started looking for aflas and ochras, and we found those. This is the concept of the test, in that we put antibodies. We know that there's antibodies made to these mycotoxins in animals. If we inject animals with trichothecene, for example, they will make an antibody. So we coat it in the bottom of the well, and then we can put a conjugate in to help pick up this metabolite. And it basically, and if you want to go into great detail, I can talk about this later with you, but we look for binding of the antibody to the substance in the urine. If there's a lot of substance, such as trichothecene or ochra or afla, it will be colorless. Just the opposite of what you would think of in an ELISA test that they do with HIV or anything else. So this is a reverse type of enzyme test. It's competitive inhibition. And the less analyte is darker. And we read these on a spectrophotometer, and they report them out in parts per billion or nanograms per deciliter. So the human health burden that we've been interested in related to chronic exposure is cancer, kidney toxicity, immune suppression, big question about autism, and neurotoxicity and depression. There are some in the audience that I'm going to have come up and be in our roundtable as well on the neurotoxicity. So we're very interested in hearing what your thoughts are as the audience in this. These are diseases that we have found are associated with mycotoxins, and these were taken from data that we collected in 2005 and 2006, especially through Environmental Health Center Dallas, as well as a number of physicians who sent us specimens. And when they coded their ICD-9s or diagnostic codes, we were able to use that. We went back and asked the physician also what the codes were. For those of you who don't know what the ICD-9 codes are, for sinusitis it's 473.8, mycosis is 117.9, bronchiectasis 494, toxic effects of mycotoxins, which we have a lot of those that come into our lab now, 989.7. And then there's death, chemical injury, and biopsies. These we've looked at, and this was our initial association in 2005, and you can see that we tested, for example, the sinusitis and nasal washes. We tested 22, 12 were positive, 10 were negative. And the other one, toxic effects of mycotoxins, nasal washes, 21, 17 were positive. But the one that we stuck with and still do today and recommend is the urine test, because 77 of those that we tested, 51 were positive. We have now done over 7,000 urines, and if they have the code of 989.7 or any of these codes, usually 80% of them are positive for one or all of the mycotoxins. So these are conclusions that are unpublished as yet. All patients with toxic effects, using especially 989.7, 74% were positive from there were three doctors I'm stating right here. 74% were positive from Dr. A, 80% from Dr. B, and Dr. C had 78%. And these were docs from different parts of the country. They weren't just from Dallas or EHCD, or they weren't just from Seattle or from the West or East Coast. So this code does help a little bit in helping us decide what kind of patients are positive. So the conclusions of this study were that there appears to be some association between mycotoxins and especially the codes 989.7 and 473.8. This test, when used in conjunction with other diagnostic procedures, and this is something I put on the bottom of our sheet, because College of American Pathology, CLIA, and FDA will not like us if we don't. But we determined that your clinical ability is the most important thing in looking at our data. The test, when used in conjunction with other diagnostic procedures, such as a microbiology culture, histological exam of biopsy samples, and especially the clinical history, may be used as an aid in the diagnosis of mold contamination or mycotoxin contamination. And further studies will determine such association. We have gone through many inspections of our validations. CLIA has come by. We've had multiple legal people say, oh, your validations are incorrect. And we have held our validations very close to our chest because there are some experts on the opposing side that say that they're wrong, and they pick it apart. We have finally decided, to heck with this, we're going full blast and exposing our validation data. And we're very proud of it, and we're going to continue to stand by this validation data. At the present time, College of American Pathology is looking at this because of another complaint from a litigator, and we feel very confident that that will pass their stringent review. Because of that, we have been asked, well, what correlations do you have with clinical patients or clinical disease? And we purposely have been looking at this for a number of years. We had 5 patients from Vanderbilt in 2006 who had urine sent to us. They were ALS patients, and they were all positive for trichothecenes. We have looked at 6 renal cell carcinomas. All of those have been positive for ochratoxin, which is not a surprise. We have looked at an Alzheimer's study with Harvard, who sent us some brains from autopsies, and it was a prospective study. They asked us to look at ochratoxin, AFLAs, and trichothecenes by the ELISA, and we conducted this on 50 milligrams of brain tissue. 6 of these were Alzheimer patients, 3 were non-dementias, and 3 were Huntington's patients. And we couldn't find any correlation with any 3 of these diseases. But that's a small number, but it does help in looking at some of the dementia patients, we believe. So is there an association between dose and response? And there have been, this is another huge discussion in circles, and Dr. Aman and I have talked, I'm sorry, Dr. Haman and I have talked many times about this issue, and we try and steer away from it because it's very complicated. But I believe there are studies that can relate, especially in animals, to looking at dose response curves. And there are some phase 1 clinical evaluations that have been done, and we mentioned that in anguidine in Dr. Strauss's discussion. Anguidine being a trichothecene that was used in cancer chemotherapy. So we have a study that the patients were given a mycotoxin and it was detrimental. The publications with mycotoxin studies, we have looked at a number of these. There's 2 patient histories published regarding human glomerular sclerosis and ochratoxin A. And this is, it's listed as in the handout that I've given you in 2012. And Jeanette Hope, who's in this audience, published this. There's further publications that are coming out and that we feel strongly are documenting the exposure of these mycotoxins, and these are all written in 2012 and from 2010 to 2012. This case I'm referring to at the very bottom is a case in Hawaii where the patients were exposed to a large number of Stachybotrys spores, and we found trichothecenes, and the baby had huge amount of trichothecene in the placenta and in the cord when the baby was born. So basically, I wanted to introduce our test, and we're going to discuss that as we go on through the day. The discussions are meant to give you a history of why we do things the way we do them, and have you understand why we're looking for certain trichothecenes or certain mycotoxins in general. The hardest thing that we've had to do is to try and expand our repertoire of mycotoxins. Very hard to make antibodies to these things in animals. We've looked at gliotoxin until the cows come home. We'd love to have an antibody to gliotoxin. We've looked all over the world for that. Very difficult to make an antibody because once it gets injected in the animals, it breaks apart and is very immunogenic, but it isn't the same thing that's produced by the organisms, especially some of the aspergillus. So the things I wanted to bring home at the end of my lecture is we do a mycotoxin test on body fluids and tissue. They're available, they're validated, they're controversial, and they're helpful to patients. Now the rest of the discussions are going to be meant on more history of why we do the things we do, and then we're going to get into the treatment, a little bit of the treatment, and we're going to talk about what they see in the pulmonary patients, and then through what intracellularly happens when Dr. Guilford talks. So again, we won't have any questions at this time. We'll take a break, and we'll be back at 10 o'clock now. Thank you.